Indirect intracanal cast metal restorations. We discussed about the introduction, definition, histological review, materials. Then now we will discuss about the indications, contraindications, advantages, disadvantages, and basic concepts for the cavity design, in, such as inlet taper, circumferential taps, feathers, and flares. So for the brief revision, we just discussed the definition of the restoration, then the types of restoration, that is direct restorative procedures and indirect restorative procedures. Indirect restorative procedures, it comes the cement, amalgam, composite, glass enamel cement fitting, or all types of dental cement fittings, which completed in single design. In indirect restorative procedure, it can inlays, onlays, veneers. Different materials are used. High gold alloys, palladium, silver alloy, chromium alloy, base metal alloy. Then we have seen the different classifications of this base metal alloys and noble alloys. Right. Then properties of the alloys. Right. And then function of each ingredient, like gold, copper, silver, platinum, palladium. Then the physical properties of all alloys. Now, uh, so now we will discuss the indications, indications for the intracanal cast restorations. So basically, intracanal cast restoration included inlays, onlays, veneers, full metal crown, partial metal crowns. Right. Again, in full metal crown, we make this again divided into metal crown, PFM crown, zirconia crown, lava crowns. All this comes into the extracoronal cast metal restorations. So in intracoronal cast restorations, there are inlays and onlays. So what are the indications of this intracoronal cast restoration? In large restorations, as we all know, it is an alternative for the amalgam restoration. So in case when there is a large cavities are present or more amount of tooth destruction occurred, then amalgam cannot provide the strength to that restoration. Uh, where we have to build up the trust, like high strength requirement is there. We want a superior control on the contacts and contours. Right. Like in case of periodontal cases where we need a proper contact and contour, we cannot build up with the help of this amalgam or composite. There may be a gap due to this matrix band placement, wedge placement. So in that cases, we have to go for this intracoronal cast metal restorations. Again, in cases there is a need for preserving the intact facial and lingual enamels. Right? If we have to preserve the facial and lingual enamels, at that time we have to do the intracoronal cast metal restorations. Okay? Unless can be superior choice over the crown. Why? Because it properly provide properly designed to the distribution of the occlusal stresses. Okay. So only here also we preserve the tooth structure. Right? Only means what? We cover all the cusp, but we don't extend the margin till the cemento enamel junctions. Right? The margin of only is only onto the occlusal tooth, right? While the gingival one third is remain as it is. So we are preserving the tooth structures. The second one is an adjunct to successful periodontal therapies. As I already told you, due to this intracoronal cast restoration, we get a proper superior control over the contacts and control developments. Right. And this, if we restore this contacts and control, and we maintain the dimensions of the contacts and control, then this health of the periodontium is preserved. Suppose if there is overhanging restoration, like you all do the class 2 restoration. If there is overhanging restoration, what happens? Excessive pressure is applied onto the periodontium. So this excessive pressure causes the loss of periodontal attachment. There is a pocket formation, and due to this pocket formation, then periapical lesion may develop, and that may hamper the tooth vitality. So if you preserve the proper contact or you maintain the proper contact and contour of the tooth, then it will help to the longevity of your restoration. Right? But we can achieve a proper contact and contour with amalgam restoration. But in some cases, like if there is a caries are extending more towards facial and lingual surfaces, where the restoration is open to the oral cavity, like at that time we have to restore the tooth with intracoronal ca- cast restoration, that is mainly preferred is India. Then again third one is a diastema closure and occlusal plane correction. In diastema closure, we generally use most commonly used material is composite restoration. Right? It is a direct restoration procedure. But what happens if suppose there is a wide gap is there, right? Near about 2 mm or 3 mm gap is there between two central incisors. At that time, our material cannot withstand that much of force, lingual force that will act on that the restoration. So at that time, what we have to do? We have to shift towards the veneers, right? And these veneers are the intracast restorations. Then for occlusal plane corrections, suppose when there is occlusal facet is there, right? There is a loss of ridge and groove pattern is there. So at that time, what we have to do, we have to adjust the occlusal plane according to the proper slopes, right? Like buccal slope, lingual slope of the tooth structures. Then the next one is those tooth which are at the higher risk of fracture, especially in the teeth having extensive restoration with fracture lines in the enamel and dentin. There is need of restoration that braces the tooth against the fracture injury. Right. So if suppose we place a composite restoration or amalgam restoration, and there are more cracks present periphery to the restoration. So what will happen? This amalgam restoration will act as a wedge, and due to this wedging effect, this crack may propagate deep into the tooth. So to avoid that, what we have to do? We can go for the onlay or full crown. Right. What will this only do? It will cover all the fractures lines. It will envelop the fractures, like fracture line. So there will be no propagation of fracture line. Right. Then restoration of the endodontically treated tooth. Onlay has been a thoughtful design to distribute the occlusal load and reinforce the restoration. Basically, what happens in the endodontically treated tooth, there is a reduction in the natural tooth structures, right? We prepared a access opening. When we do the access opening, vast amount of natural tooth is destructed. Right. So to strengthen the tooth, we have to place a post-obturation restoration. But due to this post-obturation restoration, it may cause a wedging effect. Right. Already there is due to the loss of pulp tissue, the tooth get dehydrated. It is as the tooth get dehydrated, it is more prone to the propagation of fracture length. So to avoid all this, we have to go for the full crown or only. The most preferable here, I think, after restoration, after root canal treatment, we have to go for the full crown. Okay. Then removable prosthodontic abutments, that is, it allowed to withstand the better forces imparted by the partial dentures, partially subgingival restorations. It is most compatible with the periodontia. Okay. Here, here, what is why we have to go for this inlay or onlay in case of subgingival restorations? As you all know, due to the cranicular fluid in the gingival sulcus, we cannot place composite over there. If we place amalgam, due to this cranicular fluid, there is a dissolution of amalgam restoration takes place, and there will be a micro leakage formation. So to avoid this micro leakage formation, in case of subgingival restoration, we prefer inlays, like properly contoured noble metal inlays, mostly gold. Now we come to the contraindications. where we have to avoid this inlay. We cannot give a inlay in a patient having a high caries rate, right? Because what happens due to this preparation of inlays, we have to cement this inlay onto the tooth surface. So there are three interfaces, right? Tooth cement, cement inlay interface. So the most weakest part is cement, which lute the inlay to the tooth structure. So over a period of time, this luting cement is get dissolved into the oral cavity, and at this time there will be a accumulation of food, and then it will be, causes the caries production. Right. But if a normal healthy patient is there with less caries incidence, that propagation, the caries formation will be less over there. But in case of high caries patient, if a small amount of caries has been developed, then it will rapidly spread. There will be a rapid spread of caries takes place, and more destruction of the tooth structure will occur. The second contraindication is in a young patients. In young patients, what happens? The pulp horn is large and more numerous. Pulp horn is very large and it is at a higher level. So, if we prepare a cavity, or there are more chances of exposure of this pulp horns. Again, for young patient, it is very difficult to this means longer appointment are needed for this inlay preparation. And younger patients, um, they get irritated, and then it is very difficult to manage these patients. Again, in young patients, the clinical crown is very short. So, for indirect restorations to have a good retention, we need a proper depth of the cavity. Right? In shorter clinical crown, we cannot increase the depth of the cavity. So, in these cases, we have to avoid the intracaronal restrictions. Also, their oral hygiene is poor in case of young patients, as they don't know the impression techniques. So, there are more chances of caries production. The next disadvantage, contraindication is aesthetic. Like, yeah, we all know that is metallic inlays. They are due to the metallic color, they are less aesthetic. But due to the recent advances in ceramic and the composite inlays, this drawback is this contraindication is not there. Right? We can use, if the patient wants aesthetic, we can go for this ceramic uh, inlay, or we can either go for the composite inlays. The next contraindication is small restorations. Like suppose there is a pinpoint caries is there, so we can restore this with amalgam or composite. What happen if we want to restore this with inlay? No, I want to do. At that time, you have to do the excess tooth cutting. Plus, what happens? This small intracoronal restoration will act as a it acts as a fulcrum, and due to this wedging effect, then there will be a more crack propagation in that tooth. Then fifth contraindication is occlusal disharmony. Where there is a occlusal interference, there is a defect in the stomatogasthic system. At that time, we have to we have to avoid the inlays. The next one is, what are the advantages of this? The first one is definitely strength. There is inherent strength to restore the large damaged or missing areas, protect the tooth from the future fracture injury. Then biocompatibility, it is noble metal alloy is there, so there is more biocompatible. Gold is the most biocompatible compatible metal we are having. Also, low wear, it can easily withstand the higher occlusal load, and control over the contacts and contours. Here you have to note that the best part of inlay and onlay is we can control the contacts and contour, as we have to prepare the extraoral wax pattern fabrication. So, but there are some disadvantage of this inlay. So what, the number of appointment and higher chairs at times. Like as you all know, I mean, when you do the composite amalgam restoration, yes, you have to do the cavity preparation, apply base, and do the restoration. Right? It is a one visit procedure. It will take hardly 45 minutes to 1 hour to complete all the procedures. But for the preparation of an inlay, you have to prepare a cavity. Then you have to take an impression, right? So again, you have to call the patient for the cementations. So number of appointment is also increases and the chair side time also increases, right? Then in between the appointment, we have to give the temporary restoration, right? You cannot prepare a cavity and leave it like that. You have to restore this cavity with some temporary restoration. Also, due to this repeated appointment and casting procedure, the cost of the treatment also increases. Again, it is a very technique sensitive because it requires a multiple steps. If we do any wrong in any, we get wrong in any steps, then it will be very difficult to correct that. What happen if we do the normal class 1 cavity preparation? If there is any problem in the cavity preparation, restoration rate fractures, we can easily uh, re-restore that tooth structure. But in case of casting, if there is any problem in this, we have to again start from the cavity modifications, then impressions, then again casting. So it's very technique sensitive. Then here it also has a splitting forces and most important, inability to match the natural tooth color. But now disadvantage is there is no more as we can prepare composite or ceramic veneers. Like this is next one is more preparation prior to the cast restoration. It is not it is just clinical parts. You have to remember you have to control the plaque, then control the caries, control the perioral problems. Right? Do the scaling and polishing before the starting of the case. Then before you have to clear all the caries portion or rampant caries or uncontrolled caries should be halted. Amalgam restoration IPCs should be done before starting the patients, right? And periodontium should be healthy. Then proper foundation, control of pulpit condition, and occlusal equilibrium. This is not so important for your uh, theoretical part. Now we will discuss what is the basic concept of cavity design for the cast resolution. Already Sunanda ma'am have taken your lecture regarding this inlay. Right? So here we are discussing the some basic parts or basic concept for the tooth preparation. So regarding the preparation part, there has to be a single path of insertion, right? Opposite to the direction of the occlusal loading. All reduction in the restoration that is intra or extracoronal should be oriented towards the one part. Means you should be able to withdraw the wax pattern only in one direction, right? Or here also, if you prepared a crown, your wax pattern removal should be in the only one direction. If suppose there is irregular taper, right? So what happens? You can remove the wax pattern from any direction, from here. So there will be multiple path of insertion, and retentive factor is reduced. Right? So your path of preparation should be single. Then apico-occlusal taper of the preparation, right? Apico-occlusal, huh? Apico-occlusal taper of the preparation. As you all know, for inlay cavity preparation, we require slight divergence, right? 2 to 5 degree to the opposing walls. So slight divergence of the opposing wall intracoronally and slight convergence of the opposing wall opposing axial surfaces extracoronally, right? For inlay, we want this slight divergence, and for crown we want slight convergence. So, taper, what is the function of the taper? It permits an unobstructed removal of the wax pattern and seating of the subsequent posting, right? It will be very difficult to remove if there is any undercut in the cavity. So what happens when we melt the wax? Then wax will flow into these undercuts, and due to the undercuts, when we try to remove that wax pattern, there will be fracture of the wax pattern. I mean, this is the same line of draw. It is the axis of the taper. Right here, you can see there is a single line of draw. Hmm? Here we have to place the wax pattern in this direction only and remove the wax pattern in this direction. There is a single path. Describe the path of insertion and removal of the casting. For class 1 and class 2 preparation, the line of draw parallels the long axis of the tooth structure. Right here, if suppose it is a class 2 cavity, the line of draw is parallel to the long axis of the tooth. Right. While in case of class 5, right, on the which is on the gingival surface, so the line of draw is generally perpendicular to the long axis of the tooth. And generally, basically, the line of draw bisect the angle formed by the convergence of the tapered cavity walls to the point of their insertion. Now we will discuss about the degree of tapers. So generally, what means no uniform degree of taper can be stated to be ideal. It will vary from the cases to cases. Like according to Student and Mozuk, there should be 2 to 5 degree of taper. But according to Charbino, it can increase up to the 5 to 8 degree taper. So, but what we have to take a consideration is there should not be more than 10 degree of divergence. If we increase the divergence more than 10 degree, then there will be a uh, loss of retention and more path of insertion will be present if the is convergence sorry divergence is more than 10 degree. So here degree of taper varies according to the following factors, that is the length of the preparation walls and, or the axial surface. Or it is directly proportional to the length of the preparation wall. Means if the length of the preparation wall is more, then your taper should be more, but it should not exceed 10 degrees Celsius. If the your tooth is very short or the your cavity depth is very less, then parallelism should be maintained. Right. Dimensions and the detail of the surface involvement and the internal anatomy. Right. Greater the surface, more detail the internal anatomy, and greater will be the friction, and more will be the retention. Taper has to be increases to diminish the friction, but not exceed than 10 degree. Right. To decrease the friction, we have to increase the taper. But here the limit is 10 degree. You cannot increase the taper by more than 10 degree. So the need for retention. Right? Here two diagrams are there. In the first diagram, what here equal divergence is placed on the both side. But in some cases, what happens? We have to give excessive divergence in one side, and at that time you have to maintain the parallelism on the other side. Right? But you cannot give a uneven taper. Here what is here tapered is less, here more taper is more divergent is given, right? So what happens, this will cause a more path of removal in the wax pattern fabrication, and there will be loss of retention in the final castings. In some cases what we have to do, if there is due to the caries and what we have to give a taper in two different planes, right? If the cardiogenic and the anatomical condition dictate two different tapers for opposing walls, we have to create a two planes, right? First, you don't give any taper, maintain the parallelism in the apical third region, while in the coronal region you can give a slight taper, but of equal dimensions. Right? Here, if you are giving 2 degree taper, here also you have to give a 2 degree taper. Then the next part is circumferential time. I think we will discuss this in the next lecture, uh, because here we have to discuss about the bevels and the uh, flares. And Then we have to discuss the one case of inlay preparation. Right, ma'am, I have told you about the theoretical part regarding this inlay. Then we will learn the uh, clinical aspect of inlay restoration.